The KEYNOTE-062 trial abstract was just disembargoed this morning at 8:30 Eastern Time. So I have some updates, but not from the talk. But the bottom line is that we were looking for the role of immunotherapy, pembrolizumab, which is a checkpoint inhibitor, for treatment of newly diagnosed or recurrent metastatic adenocarcinoma of the stomach, or GE junction. There were two groups randomized. The group that is, I think, perhaps surprising is they randomized pembrolizumab versus chemotherapy, and those were non-inferior. The second group was chemotherapy plus pembrolizumab versus chemotherapy, and in that group the combination was better. The toxicities were similar, and the final conclusion is that there was a stratification of these patients based on CPS score for the marker. It'd be interesting to see what the results are on the unselected population, but I don't have that data. This is a study in recurrent metastatic squamous cell cancer of the head and neck. There were three groups that were then compared. One group was the extreme regimen, which is chemo plus cetuximab versus pembrolizumab. The second group was chemotherapy plus pembrolizumab versus the extreme regimen. And the third group was pembrolizumab versus the extreme regimen. Confusing, I would argue. However, the take-home message for me is, number one, there is a benefit in the combination arm of pembro plus chemo versus extreme. And number two, the comparison of pembrolizumab to chemotherapy showed non-inferiority in the total population. And again, just like KEYNOTE-062, there was a benefit as you stratified for expression of the checkpoint inhibitor marker. As mentioned, for both trials, the combination chemo plus pembrolizumab was statistically significantly superior for overall survival versus chemotherapy alone. So one option is to combine pembrolizumab plus chemotherapy to attain greater benefit for the patients versus chemotherapy alone. However, certainly the groups also showed that if you were interested in giving pembrolizumab alone, it was non-inferior to chemotherapy, but the toxicities were less. The study of predictive biomarkers for immunotherapy is broad and complex, especially for me. However, the studies in particular looked at CPS score, which is expression of the PD-L1 marker in these tumor types, and that is validated as a predictive marker for increased survival versus non-selected populations. What we need to do, in fact, I would say the holy grail of oncology, is to be able to identify patients who respond versus those who don't. Therefore, you can pre-select who to treat with what drug. So if we can find better markers in tumors or in patients in general that allow us to select for use of these checkpoint inhibitor therapies, we'll have made a lot of progress.